All right, welcome back to MooseMed. Today we're going to be covering the clinical correlations of GI Week 1. And I want to start today with a little inspirational quote because, sometimes medicine can get a little shisty and you just need a little pick-me-up. And today's quote comes from Jake the dog. To live life, you need problems. If you get everything you want the minute you want it, what's the point of living? And honestly, I think being in STEM and studying medicine, here you are watching this YouTube video, nothing more relatable than that. So, with that said, let's dive right in. All right, starting out simple but very testable, abdominal protuberance. This is not a diagnosis, this is just a physical exam finding. What we're talking about here is the outward bulging of the abdominal wall, most commonly because of increased intra-abdominal pressure or a weakened abdominal wall. And that distinction matters because boards love asking why an abdomen protrudes, right? Not what disease it is. So clinically, think about situations where pressure inside the abdomen is chronically elevated, like obesity, pregnancy, ascites, or situations where the wall itself isn't doing its job. A good mental image is a balloon. Either you're overinflating it or the rubber has worn out. Same outward result, right? Different underlying reason. So on a physical exam, this is something you just see. You're not ordering labs for abdominal protuberance. You're being asked to interpret what it suggests. And that's why exam questions will phrase this as, the patient's abdomen protrudes. What explains this? Not, what is the diagnosis? Some common buzzwords to lock in here are increased intra-abdominal pressure, weakened abdominal wall, obesity, and pregnancy. If you see those paired with protuberant abdomen, that's your cue that this is a finding, not a pathology by itself. So now we are taking that idea of the abdominal wall weakness and turning it into an actual diagnosis, which is the anterior abdominal wall hernia. A hernia is when abdominal contents push through a weak point in the abdominal wall. That weak point already exists. Hernias don't just happen randomly. They happen at predictable anatomical locations where the wall is thinner or disrupted. So clinically on exams, the big picture idea here is anything that raises intra-abdominal pressure, coughing, straining, heavy lifting, makes the hernia more obvious. That's why one of the biggest buzz phrases you'll see is bulge that increases with Valsalva. If the bulge pops out when the patient coughs, you should immediately be thinking hernia. Testing-wise, they're not asking you to diagnose hernia in a vacuum. They want to know where it occurs and why that location is weak. That's why you're expected to recognize specific types. So we have 4 different types here. We have an umbilical hernia, and that's through the umbilical ring. We have an epigastric hernia, which is along the linea alba. We have a Spigelian, which is along the linea semilunaris. And then you have an incisional, which is through a prior surgical scar. That last one is pretty high yield clinically. If a patient has a history of abdominal surgery and later develops a bulge at that scar, that's an incisional hernia until proven otherwise. I think the big key takeaway here is that hernias are structural problems, not inflammatory ones, right? Okay, so now moving on to the inguinal region. This is super high yield because inguinal hernias are the most common abdominal wall hernia. My uncle actually has one. Pretty cool, I guess, not really. You have 2 flavors that you must be able to distinguish, and that's an indirect versus a direct. Before we get into that, though, let's zoom out conceptually. An inguinal hernia occurs because the inguinal region is an intentional weakness in the abdominal wall. The inguinal canal exists to allow structures like the spermatic cord to pass through that wall. And anytime anatomy is designed with a hole in it, hernias are just going to take advantage of that. So clinically, patients show up with a groin mass that increases with coughing or straining, and that's your entry point. From there, exams want you to decide which type you're dealing with. So let's start with an indirect inguinal hernia. This one is congenital. It's due to a persistent processus vaginalis, meaning the pathway that the testes use during development never fully closed. An indirect hernia enters through the deep inguinal ring, is lateral to the inferior epigastric vessels, travels within the spermatic cord, and can extend into the scrotum. So if you hear a young patient, congenital, or scrotal involvement, think indirect. The bowel is basically retracing the path the testes took during development. And with a direct inguinal hernia, this one is actually acquired. Okay, it happens because of weakness in the abdominal wall over time, not a developmental defect. A direct hernia pushes through Hasselbalch's triangle, is medial to the inferior epigastric vessels, and does not go through the deep inguinal ring. Usually does not extend into the scrotum either, but there are exceptions. This is what you would see in older adults, especially with chronic increased pressure. Think chronic cough, constipation, or heavy lifting. So yeah, I'd say the exam golden rule here is if it's lateral to epigastric vessels, think indirect. If it's medial, think direct. That single relationship answers most inguinal hernia questions. And just to really hammer this point at home, I guess the bottom line would be indirect means congenital, lateral, deep ring. It can reach the scrotum. Direct, it's acquired, medial through Hasselbalch's triangle, and it stays local. All right, now we're moving on from wall problems to what's happening inside the peritoneal cavity, starting with peritonitis. And this one is pretty common. So peritonitis is the inflammation of the peritoneum. And the key here is that it's not subtle. Patients are sick, uncomfortable, and guarding for a reason, right? So how this gets tested is through pain patterns, not fancy diagnostics. So exams want you to distinguish diffuse versus localized abdominal pain because that tells you which layer of peritoneum is involved. So breaking it down into a high yield distinction, visceral peritoneum, right? So that's going to be the shiny stuff lining organs. So visceral peritoneum irritation causes poorly localized dull pain. Patients can't really point to it. Whereas parietal peritoneum irritation causes sharp, localized pain. Patients know exactly where it hurts. That's why conditions like appendicitis often start as a vague pain and then localize. The inflammation spreads from visceral to parietal peritoneum. Common causes you're expected to recognize include things that spill contents into the peritoneal cavity. So perforated gastric ulcer, appendicitis, diverticulitis, pancreatitis, trauma or surgery, and in cirrhosis, you got spontaneous bacterial peritonitis. There's a bunch. Clinically, these patients look pretty miserable. So here's some buzzwords you should start to kind of associate. You got severe abdominal pain. You got rebound tenderness, guarding, and then you also got board-like abdomen, which means it's reflexive muscle tightening to protect an inflamed peritoneum. So really, really hard. So the takeaway here is simple, but it's really critical, right? Peritonitis is diagnosed by how the pain behaves and how the abdomen feels. If the pain is sharp, localized, and the patient is guarding, the parietal peritoneum is involved. All right, now we're talking about ascites, which is essentially the fluid version of increased intra-abdominal pressure. So ascites is the accumulation of fluid in the peritoneal cavity, and clinically it's most often downstream consequence of portal hypertension. That relationship is extremely high yield, and I can retouch on that once we actually cover portal hypertension. If you see ascites, you should immediately be thinking about liver and portal circulation. Testing-wise, ascites isn't just fluid in the belly. They want you to know where fluid goes in the peritoneal cavity. So fluid doesn't distribute randomly. It follows gravity and anatomical compartments. So key spaces to know would be the supracolic compartment, which is subphrenic recesses, and hepatorenal recesses. It has a name. I believe it's Morrison's pouch. And then you got infracolic compartments, and these are going to be your paracolic gutters and infracolic spaces. And then you also have the lesser sac. That's why imaging questions love asking where fluid collects first in a supine patient. Morrison's pouch, by the way, is the classic answer there. And on physical exam, ascites presents as abdominal distension and a fluid wave. Patients may also have weight gain, nausea, fatigue, and early satiety because the fluid is physically compressing abdominal organs. So common causes, you're expected to recognize are liver cirrhosis, by far is one of the most common, heart failure, kidney disease, cancer, peritonitis, or other infections. So clinically, ascites is not the problem. It's a sign of a bigger problem, usually portal hypertension. And so, yeah, high yield buzzwords to keep in mind are abdominal distension, fluid wave, portal hypertension. If those appear together, ascites should be locked and loaded. Oh my gosh, and look who it is, portal hypertension. Yeah, okay, so this is crucial because it explains why portal hypertension causes specific, very testable clinical findings. So when portal pressure rises, most commonly from cirrhosis, as stated before, blood needs an alternate route back to systemic circulation. It finds that route through portocaval or portosystemic anastomoses. These are normal connections that become a problem only when they're forced to handle too much flow. The images on the side show the 4 classic anastomotic sites you are expected to recognize both anatomically and clinically. So the first one would be that esophageal anastomosis. Oh my gosh. This is between the left gastric vein and esophageal veins. So the left gastric vein is the portal portion and your esophageal veins are your systemic. So clinically, this leads to esophageal varices. These are dangerous because they can rupture and cause massive upper GI bleeding. If you see hematemesis or vomiting blood in a cirrhotic patient, this should be your first thought. Next, we got the paraumbilical anastomosis. This occurs between the paraumbilical veins, which are your portal portion, and the superficial epigastric veins, which are your systemic portion. When these veins become engorged, you get caput medusa, which literally means head of Medusa. Dilated, radiating veins around the umbilicus region. It's dramatic, visible, and very board-friendly, which is nice. And then you got your rectal anastomosis. This connects the superior rectal vein, which is your portal portion, with the middle and inferior rectal veins, which are your systemic portion. And clinically, this can cause internal hemorrhoids. And an important distinction there is that portal hypertension causes internal hemorrhoids, right? Not external ones. That detail will get tested. And then you got retroperitoneal anastomoses. These occur between colic veins, which are your portal portion, and retroperitoneal veins, which will be your systemic portion. These aren't visible on a physical exam, but they matter because they're another way the body tries to bypass the liver. So the big picture takeaway is all 4 sites exist normally. They only become pathologic when portal pressure becomes too high, forcing blood to reroute. So the mental map you want to start to develop is portal hypertension leads to blood backing up, blood reroutes through anastomoses. Each site produces a predictable clinical finding. If you memorize these as location then symptom, you got it covered. All right, so this slide introduces TIPS, which is basically medicine saying, fine, we'll make our own bypass. And TIPS stands for transjugular intrahepatic portosystemic shunt. And it's a procedural way to reduce portal hypertension when conservative management isn't cutting it. So mechanistically, TIPS creates a direct connection between the portal vein and the hepatic vein, allowing blood to bypass the liver and flow straight into systemic circulation. Portal pressure drops, and the complications tied to that pressure, like ascites and variceal bleeding, improve. Clinically, this is used in patients with refractory ascites, recurrent esophageal variceal bleeding. You got advanced portal hypertension despite medical therapy. But here's the exam trap. TIPS helps portal hypertension, but worsens hepatic encephalopathy. Why? Because blood is now skipping liver detoxification, right? Ammonia and other toxins that would normally be metabolized by the liver are suddenly circulating freely and reaching the brain. So if you see a question that says patient had improvement in ascites but now has confusion and, other bad stuff going on with the brain, that's post-TIPS hepatic encephalopathy. So key buzzwords to anchor would be decreased portal pressure, bypasses the liver, improves ascites and varices, increases ammonia though, right? And that would lead to encephalopathy. Okay, now we're moving on to bilious versus non-bilious vomiting. And depicting that, we have one of my favorite Pokemon, Pikachu, and the lovely green alien from Futurama that shows up from time to time to represent bilious vomit. This slide looks simple, but it's one of the fastest localization tools you'll ever get on exams and in real life, bilious versus non-bilious, right? So the entire distinction hinges on where the obstruction is relative to the ampulla of Vater, which is where bile enters the GI tract. So non-bilious vomiting, this means no bile is present, right? So the obstruction is proximal to the ampulla of Vater. So clinically think esophageal obstruction, gastric outlet obstruction, pyloric stenosis, which is commonly seen in infants. We'll see that later. The vomit typically clear or milky, never green though. That's because bile physically cannot reach the stomach. It enters downstream. So the high yield example here would be an infant with projectile non-bilious vomiting is pyloric stenosis, right? If it's not bilious, pylorus should immediately be on your radar. So with bilious vomiting, this is green vomit, and it's a red flag, especially in infants. So bilious vomiting means the obstruction is distal to the ampulla of Vater. So bile can enter the lumen, but can't pass forward. Clinically think duodenal atresia, midgut volvulus, which we'll get into later, intestinal malrotation, and small bowel obstruction. So in neonates, bilious vomiting is considered a surgical emergency until proven otherwise. And exam shortcuts basically would be green vomit is obstruction is past bile entry, no bile obstruction is before bile entry, right? It's pretty straightforward. Okay, now we take that non-bilious vomiting concept and apply it to one of the classic pediatric pathologies. We have pyloric stenosis. So pyloric stenosis is caused by hypertrophy of the pyloric smooth muscle, or the pyloric sphincter, which narrows the gastric outlet and prevents stomach contents from passing into the duodenum. Because this obstruction is proximal to the ampulla of Vater, the vomiting is non-bilious, and that detail is non-negotiable on exams. Clinically, this presents in young infants, usually around 2 to 6 weeks of age, with projectile non-bilious vomiting after feeding. The baby is still hungry afterward. That's another little clue. On physical exams, the high-yield finding should be olive-shaped mass in the right upper quadrant or epigastrum. You won't always feel it, but when they mention it, they're handing you a little bit of a diagnosis there. For the lab correlation, it would be repeated vomiting would lead to loss of gastric acid. That leads to hypochloremic and hypokalemic metabolic alkalosis. So if you see an infant with projectile non-bilious vomiting, metabolic alkalosis, weight loss, or dehydration, that's pyloric stenosis until proven otherwise. Okay, so now we are on the flip side of pyloric stenosis, and that is duodenal atresia. This one is all about bilious vomiting and embryology. So duodenal atresia is the congenital absence or complete closure of the duodenal lumen. Unlike pyloric stenosis, this obstruction is distal to the ampulla of Vater, which means bile can enter the GI tract, it just can't go anywhere. That's why the vomiting here is bilious. If you remembered nothing else, remember that duodenal atresia is bilious vomiting in a newborn. Clinically, this presents very early, often within the first day of life, with bilious vomiting, abdominal distension, failure to tolerate feeds. The imaging finding they love is the double bubble sign on abdominal x-ray that represents one bubble being the stomach and the second bubble being the proximal duodenum, and no gas beyond that point. For the high-yield associations here, duodenal atresia is classically associated with Down syndrome. If a question mentions a newborn with trisomy 21 and bilious vomiting, this diagnosis should be automatic. The embryology tie-in here, and unfortunately this does matter, duodenal atresia results from failure of the duodenal recanalization during development. That's the mechanisms exams and boards will be probing when they're asking, why does this happen? So the contrast to lock in here is pyloric stenosis is non-bilious, weeks old, and metabolic alkalosis, whereas duodenal atresia is bilious, day 1, double bubble, and Down syndrome. Okay, so this slide is one of those do not miss pediatric emergencies. So if you hear this story clinically or on an exam, alarms should go off immediately. So malrotation means there was abnormal rotation and fixation of the midgut during embryologic development. On its own, malrotation can be silent. The danger is what allows to happen next, which is volvulus. Volvulus is when the midgut twists around itself, and when that twist involves the mesentery, you're not just blocking the bowel, you're cutting off blood supply, leading to ischemia. That escalation is the entire point of this slide. So the classic presentation is listed here, and it's extremely high yield, which would be bilious vomiting, acute abdomen, infant or young child. Bilious vomiting, again, tells you that this is distal to the ampulla of Vater. So you're dealing with midgut pathology, not stomach or pylorus. Add acute abdominal pain, and now ischemia is on the table. So the line at the bottom of the slide, midgut problem until proven otherwise, is not an exaggeration. In pediatrics, bilious vomiting is surgical emergency until you rule it out. A good way, one of my friends taught me to think about it, is if you take your headphones, right, and you put them in your pocket, and then you pull them out, and they're even more twisted than before, it's kind of the same idea. I think it's a great way to visualize it. All right, so this slide is a classic example of embryology coming back to haunt you. Here it is again. So Meckel's diverticulum is caused by a persistent vitelline duct, and the key phrase here is that it's a true diverticulum, meaning it contains all layers of the bowel wall. That detail separates it from acquired diverticula and shows up in many exam stems. The classic presentation is what really matters here, so you're going to have painless lower GI bleeding and a child or young adult. If a kid shows up with maroon stools or painless rectal bleeding and otherwise looks fine, Meckel's diverticulum should jump to the top of your list. The painlessness is the giveaway there. So why does it bleed? Because Meckel's diverticula often contain ectopic gastric mucosa, which secretes acid. That acid ulcerates adjacent ileal mucosa, leading to bleeding. So not inflammation, not infection, just quiet erosion. Now, this is where the rule of twos come in. So you don't need to recite it, but it's good to be able to recognize this. So it occurs in about 2% of the population. It's about 2 feet from the ileocecal valve. It's about 2 inches long and often presents before the age of 2 and can contain 2 types of ectopic tissue, most commonly gastric. So besides the rule of twos, your exam shortcut here should be painless lower GI bleeding in a child, and as stated before, those rule of twos. So Hirschsprung's disease. This slide is all about understanding how structure determines function. And in Hirschsprung's disease, the structure that's missing is enteric innervation. Hirschsprung's disease is caused by a congenital absence of enteric ganglion cells, specifically in the distal colon. Because of this, that segment of bowel cannot relax. The underlying developmental problem is failure of neural crest cell migration. If the nerves never arrive, peristalsis can't happen. Full stop. Right? So structurally, the distal bowel is missing. The submucosal plexus, the myenteric plexus. Without those plexuses, the bowel stays tonically contracted. That creates a functional obstruction, even though nothing is physically blocking the lumen. So what happens upstream? The proximal bowel dilates because contents keep moving until they hit that non-relaxing segment. That's why imaging shows a narrow distal segment with a massively dilated proximal colon. Clinically, this presents in infants often with failure to pass, abdominal distension, vomiting, and severe constipation. The image on the right drives this home visually, so take a good look at that. And so the high yield principle at the bottom of the slide here is very critical. Motility requires enteric innervation, right? No nerves means no relaxation, which means obstruction. So Hirschsprung's disease is distal colon. It's a ganglionic. The problem is motility, not anatomy alone. Okay, so this slide brings us back to our good friend the hernia. Did you miss him? He's back. This time, the problem isn't the abdominal wall, though. It's the esophageal hiatus of the diaphragm. So a hiatal hernia occurs when abdominal contents herniate through the esophageal hiatus into the thoracic cavity. The key here is that this is a diaphragm problem plus an esophageal problem, not a stomach problem by itself. There are two types, and distinguishing them is very high yield. So you have a sliding hiatal hernia, which is the most common, and in a sliding hiatal hernia, the gastroesophageal junction moves above the diaphragm. This matters because the lower esophageal sphincter loses diaphragmatic support, which makes GERD symptoms much more likely. That's why sliding hernias are strongly associated with heartburn, regurgitation, worse symptoms when lying down. If the question mentions reflux, think sliding hiatal hernias. Then you have the other one, which is paraesophageal hiatal hernia. Here, the gastroesophageal junction stays in place, but part of the stomach herniates next to the esophagus. These patients may not have reflux, but this type is more dangerous because it can lead to gastric strangulation, ischemia, right? So kind of similar to volvulus in that regard. So sliding equals reflux problem. Paraesophageal equals strangulation risk. And so the diagram on the slide here is doing a lot of work. Normal anatomy shows that gastroesophageal function below the diaphragm, and then hiatal hernia shows loss of that normal separation there. So if you just needed a quick shortcut here, gastroesophageal junction is moving, that would mean sliding. If the stomach moves and the gastroesophageal junction stays, that's paraesophageal. All right, sorry for the bloody image, but I thought it was a very, very, very good surgical image that was available for free, so I decided to include it. So this slide introduces paraduodenal hernias, which are sneaky because they're internal hernias. Nothing bulges on the outside, but a bowel can get trapped, which is just as bad. Paraduodenal hernias occur due to abnormal midgut rotation during development. Because the rotation isn't normal, the peritoneum forms abnormal potential spaces, and loops of bowel can slide into them and get stuck. That's why the key phrase on the slide is internal herniation of the bowel. There's no defect in the abdominal wall, right? This problem is entirely inside the peritoneal cavity. Anatomically, these hernias occur near the duodenum, which is important because it links this to pathology back to the midgut development. The failure of normal rotation creates a pocket, and the bowel loves falling into pockets. So clinically, this can present as intermittent abdominal pain, signs of small bowel obstruction, sometimes acute obstruction if the bowel becomes trapped. Because it's congenital, patients may have symptoms on and off for years before it's finally diagnosed. The images on the slide help to visualize that, so you can see bowel loops getting tucked into the peritoneal folds. And then again, that awesome surgical image shows how hidden these hernias can be until you're actually inside the abdomen. So the key concept to lock in here is that failure of normal rotation leads to abnormal peritoneal spaces, right? And like I said, your guts love to fill up those spaces. Okay, so now we're getting into the classic peptic ulcer disease, and the key is understanding where the ulcer is and why it's formed, not just memorizing symptoms. So peptic ulcer are mucosal erosions caused by an imbalance between acid exposure and mucosal protection. Two causes dominate exams and real life. So you have Helicobacter pylori infection, or you have NSAID use. So everything else is secondary. So now location matters. So with gastric ulcers, these occur in the stomach, right? We have gastric stomach. Often along the lesser curvature, and because food stimulates acid production and directly contacts the ulcer, pain worsens with eating. That detail is very testable. So patients may actually lose weight because eating hurts. Duodenal ulcers, these are usually in the first part of the duodenum. Here's the high yield contrast. Pain improves with eating. So pain returns after a few hours later or at night. That happens because food temporarily buffers the acid, but once gastric emptying occurs, acid hits that ulcer again. The slide images usually show crater-like lesions, right? And that's not just to make it super easy to see. Ulcers literally bleed, perforate, or penetrate into nearby structures, which is why things get pretty bad pretty quickly. So major complications to recognize here are bleeding, perforation, sudden severe pain, right? Peritonitis, penetration, pain radiating to the back, think pancreas, right? So the exam anchors here are going to be the NSAID use. So that decrease in prostaglandins would lead to a decrease in mucus and bicarbonate, or Helicobacter pylori, which would cause inflammation and increase acid effects. If you ever had a canker sore, this is like a super bad canker sore. All right, and then also a bonus clinical correlation here is Zollinger-Ellison syndrome. I don't have it on the slide here, but this is really important. So Zollinger-Ellison is caused by a gastrinoma, right? So a tumor of the stomach or pancreas, and it's a gastrin-secreting tumor, most commonly located in the duodenum or pancreas region, right? So excess gastrin leads to massive acid hypersecretion, and everything downstream follows from that. So these patients get multiple recurrent and severe peptic ulcers, often in atypical locations, sometimes even beyond the first part of the duodenum. If ulcers keep coming back despite treatment or show up where they shouldn't, think Zollinger-Ellison. Key clinical feature to anchor here is refractory peptic ulcers, abdominal pain, diarrhea, and that's because acid inactivates pancreatic enzymes and damages intestinal mucosa. Very high gastrin levels. That's like the biggest one. And so connecting that back to physiology, because this is where exams like to test, gastrin normally stimulates acid secretion, but low gastric pH should shut gastrin down, right, via that negative feedback loop. In Zollinger-Ellison, though, that feedback loop is ignored because that gastrin is coming from a tumor. That tumor just keeps pumping it out, and gastrin, it just keeps flowing, regardless of how acidic things get. All right, now let's talk about the spleen. And the reason Abe Simpson is on here is because I remember as a kid, the first time I was able to comprehend The Simpsons, this man came flying through a window and fell on his tush, and he screamed, "My spleen!" Which now I realize makes zero sense, but maybe that was the funny part of it, right? But anyway, that's why he's here. Let's talk about the spleen. It does a lot of work and causes a lot of problems when it enlarges or gets injured. So first, you want to orient yourself anatomically. The spleen sits in the left upper quadrant and is tucked under ribs 9 and 11, and it's highly vascular. That vascularity is the reason this organ is clinically important and surgically very dangerous. So functionally, the spleen has two big jobs. One, you have filter blood, which is to remove old and abnormal red blood cells, and you also have immune surveillance, especially against encapsulated organisms. So that function explains splenomegaly. And splenomegaly means enlargement of the spleen, and it's almost never a primary disease. It's a sign of something else. So the high-yield causes to recognize would be portal hypertension, very common. You got hematologic diseases like leukemias, lymphomas. You have some infections like EBV, mono is the classic example. Clinically, an enlarged spleen can cause early satiety because it starts to compress the stomach. Then you also have that left upper quadrant fullness. And then you also have hypersplenism, where the spleen overfilters and causes low platelets, red blood cells, or white blood cells. If the stem mentions cytopenias with splenomegaly, that's hypersplenism until proven otherwise. Now, shifting gears, because this is where exams love to go, you have splenic trauma. Because the spleen is soft and vascular, it's the most commonly injured organ in blunt abdominal trauma. So the classic scenario is like left-sided abdominal trauma or left upper quadrant pain, referred pain to the shoulder, which is also called Kerr's sign. That shoulder pain happens because blood irritates the diaphragm and refers pain via the phrenic nerve. If they mention shoulder pain after trauma, that's not random. It's pointing you to the spleen. And so the biggest danger with splenic injury is hemorrhage. Patients can look okay initially and then decompensate very quickly. That's why splenic trauma is managed cautiously and often non-operatively if stable, but aggressively if unstable. So the big exam takeaways here are splenomegaly is a systemic disease clue, whereas splenic trauma usually means bleeding risk, and left shoulder pain after trauma should lead you straight to the spleen. All right, gallstones. And here we have Ben Grimm, aka the Thing from the Fantastic Four, representing a big old gallstone. So gallstones are one of those topics where the mechanism explains the symptoms perfectly. So if you understand how they form, the clinical picture makes a lot more sense. Gallstones form when bile becomes supersaturated, and most commonly with cholesterol. When cholesterol concentration exceeds the ability of bile salts to keep it dissolved, crystals form, and over time, those crystals become stones. The classic risk factor are often remembered with the 4 F's. Fantastic Four, here we go. Female, 40, fertile, fat. You don't need to love the mnemonic, but you do need to recognize estrogen and obesity as risk factors because both increase cholesterol and bile. Clinically, gallstones are often asymptomatic, but when they cause problems, the location of the stone determines the symptoms. So first we have a biliary colic. This happens when the stone transiently blocks the cystic duct. Pain would be in the right upper quadrant, often after a fatty meal. Pain is intense, but episodic. No fever, no infection. The gallbladder is contracting against a blockage. That's the pain. Then you have acute cholecystitis, and this is when obstruction persists and inflammation starts to develop, right? That itis portion. So you'll get that right upper quadrant pain, fever, Murphy's sign, which is pain with inspiration during right upper quadrant palpation. At this point, this is no longer just a stone problem, it's an inflammatory one. So now look at the images on the slide. The stones themselves are usually cholesterol stones, yellow and waxy. The diagrams show how the obstruction locations changes with that presentation. So the high yield complications here is if a stone migrates, right? If it goes into the bile duct, the common bile duct, you'll have a cholelithiasis. It's a mouthful, but there it is. And then if you got it past the pancreatic duct, you have gallstone pancreatitis. If it causes obstruction and an infection, you're going to get that ascending cholangitis. Those are emergencies. They're not great. So the exam shortcut here would be that right upper quadrant pain after a fatty meal, usually means gallstones, fever, right upper quadrant pain, that should lead you to cholecystitis. If they have jaundice, fever, and pain, think cholangitis. So bottom line, gallstones are common, but their complications are not subtle, and exams expect you to localize the stone based on the symptoms. Okay, so this slide is the pancreas at a high-yield, clinically relevant level. Because pancreatic pathology shows up pretty late, it hits very hard and is pretty easy to miss. So first, anchor the anatomy, because that explains a lot of the symptoms that you'll see here. The pancreas is a retroperitoneal organ with a head, body, tail. The head sits in the curve of the duodenum, and the tail extends towards the spleen. The pancreatic duct usually joins the common bile duct at the ampulla of Vater, and that shared drainage pathway is the key to everything on the slide. So functionally, the pancreas has exocrine roles, which would be digestive enzymes like lipase, amylase, proteases, and endocrine roles, which would be insulin, glucagon, somatostatin. Most clinical pathology we worry about here involves the exocrine pancreas, though, because those guys do a lot more damage. So pancreatic cancer, this is a big one, and exams are very pattern-based with it. Most pancreatic cancers arise in the head of the pancreas. Because the head sits right next to the common bile duct, tumors here often cause biliary obstruction. That leads to the classic presentation of painless jaundice, dark urine, pale clay-colored stools, pruritus, weight loss. If the stem says painless jaundice, you're there. That is pancreatic cancer. Another high-yield association is Courvoisier sign, which is palpable, non-tender gallbladder and jaundice. This suggests malignancy, not gallstones, right? If you can feel that gallbladder, that is some hyperplasia going on. Not good. Pain, when it occurs, is often epigastric and radiates to the back, especially with tumors involving the body or tail. That's because the pancreas sits right in front of the retroperitoneal nerves. Risk factors are the pretty standard ones with cancer, so smoking, that's the biggest one. Chronic pancreatitis, older age, diabetes. Pancreatic cancer is aggressive and often diagnosed late because early disease is silent. By the time symptoms show up, obstruction or invasion has already occurred, and the damage is pretty bad. Pancreatitis is inflammation of the pancreas caused by premature activation of pancreatic enzymes, especially trypsin, which leads to autodigestion of the pancreas. Once enzymes turn on inside the pancreas instead of the duodenum, things spiral pretty quickly. So the two big causes you'll see are gallstones and alcohol. And there's a classic way to remember this, which is the mnemonic "get smashed," which what that stands for is gallstones, ethanol, trauma, steroids, mumps, autoimmune, scorpion sting, hypercalcemia / hypertriglyceridemia, oh my god, ERCP, and drugs. But exams usually stick to gallstones and alcohol. Pretty nice. So clinical presentation you'll see is pancreatitis presents with severe epigastric pain, pain radiating to the back, nausea and vomiting. Patients often lean forward because it slightly relieves the pain, and that is usually your clinical clue in vignettes. The lab clues here, it's pretty straightforward, but it's testable. You're going to see elevated lipase and elevated amylase. If they give you lipase, that's pretty specific. Amylase is a little less specific there. Gallstone pancreatitis, this ties directly back to the previous slide. A gallstone can lodge at the ampulla of Vater, blocking both the pancreatic duct, the common bile duct, and this will trap those pancreatic enzymes inside the pancreas, which will lead to inflammation. So if you see right upper quadrant pain, epigastric pain, elevated lipase, history of gallstones, that's gallstone pancreatitis. Some complications, you don't need to memorize everything, but just good patterns to recognize, so I'm throwing them at you. Is necrosis, infection, hypocalcemia, which is fat saponification. The abdominal images on the slides show pancreatic edema and inflation. That's the visual version of enzyme-mediated damage. So finally, big exam takeaways, right? You got epigastric pain radiating to the back. That should be your clue for the pancreas. Lipase levels being elevated. And then you also got gallstones and alcohol being the top causes. All right, so now we have renal vein entrapment syndrome, or if you're super awesome and fun, you call it nutcracker syndrome. Just kidding, but you should. So this slide is all about anatomy causing pathology, not disease causing disease. So renal vein entrapment syndrome happens when the left renal vein is compressed between the superior mesenteric artery and the aorta. That relationship is pretty much the entire diagnosis. This is not inflammation. This is not thrombosis. This is mechanical vascular compression due to positioning, because that left renal vein literally travels across between those two things. You can see it perfectly in the diagram, how it just gets squished there. So now think through what happens when venous outflow is blocked. Pressure backs up into the left kidney. That pressure transmits into tributary veins. Clinically, this can cause hematuria, so you're going to be peeing some blood. Not great. Some left flank pain, pelvic congestion symptoms. And by the way, that left flank pain is pretty specific, at least for vignettes. And then you also get some varicocele, especially left-sided. That last one is very high yield. The left gonadal vein drains into the left renal vein. So compression here explains left-sided varicoceles. If a question stem says left-sided varicoceles in a young male, this syndrome should be on your radar. The images on this slide are doing some important work here. You can see that SMA coming off the aorta, creating that narrow angle, and like I said, making that perfect squish there. So common pitfalls here is that this is not portal hypertension, right? This has nothing to do with liver disease, and forgetting laterality will kill you on exams. So the exam anchor here would be that left renal vein between the superior mesenteric artery and the aorta, and the venous congestion symptoms. All right, so Nutcracker syndrome is a positional vascular problem, and the symptoms make sense once you take a minute to appreciate the anatomy. All right, so now we have psoas abscess. And this slide is a great example of why knowing where something lives anatomically explains, how the patient presents, very similar to that Nutcracker syndrome. A psoas abscess is an infection involving the psoas muscle, and the psoas is not just any muscle, it's posterior abdominal wall muscle that runs from the lumbar spine down to the femur. That location is the entire clinical story. Anatomically, the psoas lies in the posterior abdominal wall, is retroperitoneal, sits close to the spine, kidney, ureters, and major vessels. Because of that, infections can spread to it from GI sources, GU infections, hematogenous spread. And so now here's the high-yield clinical correlation that the slide is pointing at. Posterior wall infections don't behave like intraperitoneal ones. Instead of the classic abdominal pain, which we discussed, patients often present with hip or groin pain, some thigh pain, difficulty walking, pain that worsens with hip extension, right? Because it's hurting your back. Your back does a lot of work. So why hip extensions though, right? Because stretching an inflamed psoas hurts. This is why the psoas sign exists. The images on the slide show the psoas muscle's vertical course and why pain can radiate down towards the thigh. That referral pattern, again, is not random. It follows muscle's anatomy. So if patient has a fever, back or flank pain, hip pain, limited hip movement, and abdominal findings are minimal, you want to be thinking psoas abscesses. Okay, so this slide is all about localizing pain based on anatomy, and we have our good friend, the Scotsman from Austin Powers, because this guy definitely suffers from all sorts of abdominal wall pain, no doubt. So the posterior abdominal wall structures refer pain differently than intraperitoneal organs. If you don't respect that distinction, you'll mislocalize pathology. So the first anchor is where we are. The posterior abdominal wall contains mostly retroperitoneal organs, so the main patterns tend to be more deep, more poorly localized, often felt in the back, flank, hip, or groin, rather than classic abdominal quadrants. So that psoas abscess would be a great example of just that posterior abdominal wall pain. So right-sided posterior abdominal wall pain, think structures that sit posteriorly on the back, right? So that would be your liver, gallbladder, right kidney. Pathology here may present as right flank pain, back pain, sometimes shoulder or scapular discomfort, especially with the diaphragmatic irritation. So this is why right kidney problems don't always scream abdominal pain. They often feel musculoskeletal at first. Left-sided posterior abdominal wall pain. So posterior left-sided structures include the spleen, stomach, left kidney. So left-sided back or flank pain should make you think about splenic pathologies, renal pathologies, posterior gastric issues. The diagram at the bottom reinforces that organs don't project pain randomly. Their position dictates the pain map, right? So the slide pairs well, like I said, with that psoas abscess slide, because posterior structures lead to atypical abdominal pain, often mistaken for MSK or hip pathology, and so you're going to get minimal peritoneal signs there. So the high yield takeaway here is if a patient has back or flank pain, minimal anterior abdominal tenderness, pain that doesn't fit really classic quadrant patterns, you should be thinking posterior abdominal wall or retroperitoneal pathologies, not intraperitoneal diseases. All right, last one, we have the abdominal aortic aneurysm. Not the fun kind of AAA that will help you with your car. So this slide is about a diagnosis you do not want to miss, because when it declares itself, it is bad. An abdominal aortic aneurysm, or AAA, is a dilation of the abdominal aorta. So for the abdominal exam, when we use our palms to measure that abdominal aorta, this is why. It's classically defined as greater than 3 centimeters. This is not an inflammatory process, it's structural weakening of the vessel wall. So the anatomy here matters more than anything else. The abdominal aorta is retroperitoneal, anterior to the spine, closely associated with posterior abdominal wall structures. And that posterior location explains a lot of the symptoms. So the clinical presentation you'll see is often asymptomatic until they aren't. When symptoms do occur, they classically include deep, constant abdominal pain, back pain, sometimes a pulsatile abdominal mass. Back pain is not incidental. It's because the aneurysm is expanding posteriorly towards the spine and retroperitoneal nerves. So rupturing is the emergency part of this. When a AAA ruptures, it's a medical emergency with a very specific pattern. Sudden, severe abdominal or back pain, hypotension, signs of hemorrhagic shock. Boards love this triad. If you see pain, hypotension, risk factors, think rupture immediately. So risk factors are going to be older age, male, smoking, which is the biggest factor, and hypertension. This is why screenings exist, right? Especially in older men with a smoking history. So why this slide belongs with posterior abdominal wall pain? Because AAA pain does not behave like intraperitoneal pathology. There's often minimal peritoneal signs, pain felt in the back or flank, and a deep, boring quality rather than a sharp tenderness. And that ties it into that posterior abdominal wall pain there. So the exam anchors you're going to be looking out for is it's a retroperitoneal vessel, right? Back pain explained by posterior location, and that rupture is going to lead to that hypotension and pain. So AAA hides quietly, hurts posteriorly, and kills quickly if missed. Well, that was week 1 clinical correlations in the books. If there's one thing to take away, it's this, right? Anatomy explains symptoms. Hernias bulge where walls are weak. Bile color tells you where the obstruction is. Posterior structures refer pain to the back and hip. And vascular positioning creates real disease. So none of this is random. It's cause and effect. If you can look at a patient presentation and ask where is this anatomically, you're already thinking like a clinician, and keep that mindset, and those correlations stop being memorization. Before you know it, it will just all click. So again, thanks for watching. Keep going. This stuff stacks and you're stacking it correctly. All right. Thank you again for joining me at MooseMed, where we take medicine by the horns.